Good morning, bright and early.
Good morning. It's a huge honor to be here. Thank you for having us. We've kind of split this up, so I'll sit down, but if there's questions that come up while it's going on, we can both take them.
Absolutely. This is a really big topic to talk about, and we wanted to break it down this morning and talk about how it impacts those who work in geriatrics. But I think, first of all, we wanted to talk about what MAID is. We'll talk about the legislation, the legal process that patients have to go through, and then we'll put that into some geriatric context and talk about how the clinical implications for you as providers and what you need to do if your patients want to talk about this issue. So a good place to start is by defining what it is we're talking about when we're talking about medical assistance in dying, or MAID, which is our short form or acronym. At the end of the day, MAID is a medical procedure. It involves the administration or the prescribing of medications to intentionally and safely end the life of an adult patient who meets strict legal criteria at the request of the patient. So when we're talking about MAID, MAID can happen legally two different ways in Canada. So we can prescribe medications to a patient that patient then would consume themselves. So that's the oral protocol. And I'll tell you that doesn't happen very often in Canada. So for over 8,000 cases, there's only been 13 cases where we've actually prescribed medications to a patient. By far, the most common way that MAID happens is through the injection of a series of IV medications. So for the purposes of today, when we're talking about MAID, we're talking about that approach to providing this service. In Canada, it's Bill C-14 that governs who is eligible and the processes under which MAID can be delivered to a patient. So it's federal legislation. It's actually an amendment to the criminal code that says under these circumstances, it is not illegal to support or to assist a person to end their life. Federal legislation, and like all healthcare in Canada, it's up to each province to decide what that looks like. And so MAID does look a little bit different in each province, and it's Bill 84 that tells us what MAID looks like in Ontario and what we need to do when we're providing that service here. So we're just about 3.5 years into this legislation. So Bill C-14 became law in Canada on June 17th, 2016. And we've learned a lot. This is a new practice, still a new practice. It's an evolving practice. And I think by the end of today, I think you'll see the complexity of providing this care and how much has changed in those past 3.5 years. So let's talk about what's in the bill. It's important to understand that these are the legal criteria that patients have to meet in order to be eligible to receive this service. So patients have to have coverage under a provincial health insurance plan. So we don't allow medical tourism in Canada. So we don't allow people to come from other countries to travel to Canada to receive this service. There aren't that many countries that do allow it, but here you must be eligible for healthcare services. Patients have to be 18 years of age, and they have to be capable of making healthcare decisions, which means they can have a conversation with you about it. They are aware of the risks and the benefits of all of the treatment options available to them. They have to know the status of their own chronic conditions, know those risks and benefits to the treatments available to them, including palliative care. So it is part of the legislation that patients need to know about palliative care as one option for treatment. And certainly in the patients that I see, about 94% of them have palliative care, active palliative care, involved at the time that they would make their MAID request. The other important thing about the legislation is that there's 3 major exclusions to this legislation. So 3 groups who do not currently have access to this. So mature minors, so patients under the age of 18. And we know that mature minors can make other healthcare decisions, but they are not eligible to make this decision about their healthcare. People whose suffering is the result primarily of a mental health issue, and it's not currently available through advance directives. So I can't write a living will today or direction today that says if I get this disease down the road, I would like to have MAID. We only take first person consent in our request for MAID, and that person has to have that and maintain that capacity to provide that consent all the way through the process. So if at any point they lose that capacity to make healthcare decisions, the process stops, okay? So patients have to make a voluntary request for MAID. They have to make it in writing, so a written request. And the written request has to be witnessed by 2 independent witnesses. So in Ontario, the Ministry of Health provides us with forms. We are not legally bound to use those forms, but we certainly encourage patients to use the forms that the Ministry of Health provides to us because it helps us ensure that the proper legal process has been followed. So patients make their written request form. And then with the witnesses, you have to have 2 witnesses in the room, and the witnesses have to meet certain criteria. So witnesses have to be 18 years of age or older. They have to understand that they are witnessing a written request for medical assistance in dying. The witnesses cannot be a beneficiary in the will, so they cannot benefit from the death of that patient in any way, and that excludes a lot of people that may be surrounding the patients. Witnesses cannot be a member of the healthcare team, okay? So that includes us, and employees at the Ottawa Hospital don't sign as witnesses. And they cannot be the owner or operator of a healthcare facility where the patient resides. And so while this is a very high level and a strict criteria for witnessing, it can also be impede access for patients. It can be very difficult for patients to find people who meet these criteria. And so we do have volunteers in our community who will be volunteer witnesses. There's no need to know the person. And so we can arrange for volunteers to come in and witness those forms for patients. Patients then need to go through 2 medical assessments. So in Canada, nurse practitioners or physicians can perform the assessment for patients to receive MAID. What they're assessing for is if patients meet the legal criteria, and I'm going to walk through what we're looking for when we're assessing their medical condition. And practically speaking, one of those assessors is generally the person who will provide the medications to the patient. So we have many physicians and nurse practitioners across our region in Eastern Ontario who are involved in MAID practice. Some of them just do assessments, and some of them both assess and will provide the medication. So practically speaking, when we're trying to sort out who's going to assess these patients, we're going to try and make sure one of those people who assesses them will then go on to provide the medications to the patients. One of the things about the written request form, and this is an important point, take-home point, because there's a lot of myths and misperceptions about what MAID is or how it works, and people sometimes mix up the mandatory 10-day waiting period. So once the patient makes a written request for MAID, that starts a mandatory minimum 10-day waiting period or a reflection period. And this was put into the legislation to allow patients time to think about what they're doing. It's a big decision. They have time to spend with their loved ones to get their affairs in order. But it's important that we understand that this is just a minimum. So if I sign my written request form today, tomorrow would start my 10-day waiting period. I would count off 10 days, and the next day after that would be the first day that they would be eligible. But that doesn't mean if I sign my request today, I have to have MAID in 10 days. It's just a minimum waiting period. And certainly what we're seeing this year is many more patients coming forward who want to get this in place for when they're ready to go ahead. And so many patients who start this process or even go through and become eligible may decide to never move forward with MAID, or they may put it on hold for several months until they decide that they're ready to move forward. So these are the medical criteria for when we're assessing patients. So patients have to be suffering from a serious and incurable illness, disease, or disability that is an advanced state of decline that cannot be reversed. So we talk about patients being on a trajectory towards death. So they have a serious illness and they are on a trajectory towards death. And sometimes patients come forward too early in their illness. And it's important to know that they have to meet all of these criteria. Patients have to be enduring physical or mental suffering, and certainly in the patients that we are seeing, it's a combination of both. So there is physical suffering, but in a vast majority of cases, it's that mental suffering or existential suffering that we're less able to manage that is a strong driving force in their request or their reasons for coming forward to learn more about this option. So physical or mental suffering that's caused by a medical condition that is intolerable to the person and cannot be relieved under conditions that are acceptable to them. So patients have to be aware of all of the treatment options available to them, but they are not obliged to try all of the treatment options. And this is where having the capacity to make healthcare decisions is so important. So if I was diagnosed with cancer, and I'd gone through my rounds of treatment and I decided I'd had enough, and I went to see my oncologist, and the oncologist said, well, wait a minute, Laura, there's this, really good RCT. I think this is the answer. It's going to solve your problems. As long as I'm aware of it, I understand the risks and benefits of that, I am under no obligation to try that treatment. Patient's natural death must be reasonably foreseeable. It does not have to be imminent within a specific time frame or the result of a terminal condition. And so some of these conditions, and we'll talk more about this, when you hear about MAID, MAID's in the paper almost every day, and the groups that are taking our laws to court or challenging Bill C-14 in the courts are generally fighting for more access. So it's groups that belong to those three exclusions, or they're challenging some of the criteria that patients have to demonstrate in order to be eligible to receive this. So by far what we're seeing is more patients fighting for access to this and opening up the law to make it available to more people. So this is just the quick overview. So patients come forward with their inquiry. And it's important to note that most patients that want to talk about MAID do not go on to receive MAID. It's about 1 in 3, but it is something that's in the news. It's something that people want to talk about or explore. And the places that they're coming forward to talk about it are in the community, to their pastoral care team, to the frontline providers in healthcare, to their physiotherapists, to their nurse practitioner at the family health team. So it's important that as professionals we know how we are to respond when patients come forward with these requests. And I always say, make sure that you go to your college guidelines, because there'll be a statement in how you're to respond if a patient comes forward with you. And it's a little bit different if you're a nurse or a social worker or a physio or a pharmacist or a physician. But patients come forward. And as a nurse, I know that the College of Nurses requires me to explore, have an exploratory conversation with that patient to say, what is it that you're actually talking about? Because sometimes patients aren't talking about MAID. Maybe they're just talking about, I wish I was dead, versus I really wish that I had some assistance to end my own life. So you have to have an exploratory conversation to sometimes tease out what it is they're talking about. And there may be other options that are more appropriate. So have some kind of a conversation with the patient. I'm required as a nurse to continue to provide care to that patient, and I'm required to inform the MRP that the patient has an interest in MAID. So at that point, based on how comfortable you are, you can provide some education, or you could refer them to something like our regional program where we can take over and provide that intake interview and provide resources for the patient. Patients then go on to make a written request form. Written request form doesn't always have to come before those assessment forms, and sometimes we actually ask that it comes after those assessments, but in general they make a written request form and we'll start to organize those 2 assessments for patients. Patients can have as many assessments as they would like. They can continue to be assessed, and they have to just find 2 people that feel that they're eligible and meet those criteria in order to move on to planning for the procedure. Again, most people that start the process don't end up having the procedure. There's patients who may decide not to proceed. Many patients just want information about this, or just feel comforted to know that this is an option that's available to them if things got too bad or if they decided that they wanted that. Some patients will go on to plan for a procedure, and I'll talk about how we do that. And some patients are found ineligible. And if there's anything that I want you to take home from today's presentation, it's to understand that the people who need the most support in this process are the patients that we find who are not eligible. We have patients who are suffering intolerably, and they may see this as an answer to their problems, and then when we come back and tell them that they're not eligible, that's a very difficult conversation, and certainly one of the more difficult parts of my role with this. So just to give you an idea of where we're at in Ontario, these are the statistics for all provisions, so just completed procedures. So remember, there's probably 3 times the number of people who've come forward that want to talk about this or who have started the procedures, and this takes us to the end of October. So we're just sitting under 4,000 cases. In Ontario, we've only had one of the patient-administered, or where we prescribe the medications to patients. By far, it's clinician-administered. We're still providing the bulk of this service in hospital, though, although it's something that we are actively trying to increase on the community side, and certainly in Champlain, we're providing more of this service on the community side than we are providing in the acute care organizations, and that's because most patients wish to die at home. MAID is something that patients can have in hospital, they can have at home, they can have in their retirement home, their long-term care home. We really do try to accommodate patients' wishes as long as we can safely provide that procedure there. That being said, there's going to be people who are too sick to go home from hospital, or because of the nature of their illness, we're going to it will be more preferable to provide the procedure in hospital. Lots of physicians and nurse practitioners involved in this in hospitals across the province. Still about a 50-50 split, and a large age range, although our mean age is still mid-70s. In the underlying conditions, all the cases in Ontario are reportable to the Chief Coroner's Office. So after we complete a procedure, we have to make a call to report it to the Coroner's Office. We're a minority in that. There's only 3 provinces in Canada who have mandatory coroner reporting. And we report the underlying medical condition under these 4 categories. So while in the early days of MAID, we were largely driven by end-stage cancer diagnosis, we're seeing that that number is coming down, an increase in sort of cardiac and neurodegenerative, but what's really increasing, particularly in the past year, are patients in that other category. And I think that's really applicable to the group that we're talking about today. We're seeing patients come forward with other chronic health conditions where it may be less clear that they clearly meet the guidelines, and so there's a lot more complexity to sorting out how we support them through this process. We're also involved, we're increasing the number of patients who are coming forward who wish to be involved in tissue and organ donation across the province. That's increasing at an incredible rate. We've certainly been involved at the Ottawa Hospital in solid organ donation. Those cases have to happen in hospital, of course, and we've been involved in developing some national guidelines for how to implement MAID alongside the request for organ donation. I'm not going to go through the numbers, but this just gives you an idea of how our numbers have changed over the years. So orange was last year, blue is this year. So we've seen a huge rise in the number of referrals that we see for this service, and it's continued to go up this fall. We heard from the Chief Coroner's Office that there's a 20% increase in provisions just in the past fiscal year. So this is something that's not going away. It's something that people want to know about. So it's important that we have accurate information to share with them about this end-of-life option. Other things that we need to think about when we're planning for these procedures. So when we receive referrals to our regional program, and we are a referral site for Eastern Ontario, we take all of the referrals from the Ontario MAID Care Coordination Service here as well. We generally start with an intake assessment. So there's myself, and we have 2 coordinators that work with, and we do the intake on all of these patients. And you want to get a sense of what it is that the patient's looking for. Are they just looking for information? Is this something that they're really interested in moving ahead with soon? when and where do they think that this might want to happen, and we get details about their health condition, because depending on what their condition is, sometimes it's fairly straightforward who we would involve in their assessment. Sometimes it may be that we need to have a specialist inform that, and at the Ottawa Hospital we have a large number of specialists from across the whole hospital involved in assessments, and we may pull someone in. So if a patient has a weird and wonderful cardiac issue, and the assessor may not know actually what the impact on that patient's lifespan would be, we may involve a cardiologist in those assessments, or at least link that assessor to a cardiologist so they can learn more about that condition and help the patient meet the eligibility criteria if they do. And we are bound by law to do what we can to support patients to be eligible. So often that involves finding supporting documentation. Sometimes people think they have something and they don't, and so we have to sort of work through that and demonstrate what diagnoses they have and the status of those chronic conditions. We certainly involved other supports for the patient. So again, at the Ottawa Hospital, we have a large team, including social work and spiritual care, neuropsychology, and SLP, again, to help our patients communicate their wishes and demonstrate their eligibility, and to support them and their family through the process. Translation, tissue and organ donation, again, a much bigger procedure to organize, and involves multiple teams, and often flying in teams for donation as well. And then once that's done and we have our patients been found eligible, we'll work with them to plan for the procedure, again, when and where they would like that procedure to happen. It's important to note that working in end-of-life care, resiliency can be an issue. And so it's important that we have access or supports for the healthcare providers who are involved in this practice. And I first became involved in 2017 when I was seconded from my position to do a review of this practice in Eastern Ontario. And I had an opportunity to travel around the province and speak with providers from across the country. And certainly what we heard loud and clear was that they needed support for this practice. So support to not only emotional support for dealing with this, but support in access, in case review, in developing a community of practice. And then as we've grown and as this is becoming more common, what we've learned is that it's not only those who are directly involved with MAID, and in fact, probably more so, it's the healthcare providers around the patients who need support. So when we go into long-term care, and we're providing a case for the first time, it's important that we support the staff to understand the process. They may have a long-standing relationship with that patient, and to make sure that everybody's okay with how it's working. So we are the Champlain Regional MAID Network. We are very lucky to receive funding to implement a regional program. We're the first funded regional program in Ontario. And again, it was in our LIN provided the funding in response to sort of our identification that we needed to have some funding to provide a framework or structure in order to support the provision of this service in a high quality, patient safety sort of focused way. So we have assessors and providers and coordinators across the region, and really our goal is to provide this care to patients wherever they might want that to happen, and to implement standardized practices so that whether you receive this care in Cornwall or at your home out in the country or up in Pembroke, that you have the access to the same service and the same high quality service where you want to receive it. And I'm not going to go through that. So it's important to note that healthcare professionals do have a right to conscientiously refuse to participate in MAID based on their moral or religious beliefs. And so like everything that we do in healthcare, the decisions that our patients make may not be in line with our own views or what we are feeling. However, again, in relation, when you look at your college documents, it's going to guide you in that. So we would never ask anyone to be involved in this that doesn't want to be involved in it. But again, you still have to provide respectful care to the patient. You do have a duty to care for them. For physicians and nurse practitioners, they do have to discuss all treatment options. they cannot impede access to this service, and they have to provide an effective referral. And this has been challenged and upheld in the courts. And so for physicians, nurses, pharmacists, whoever may be getting these requests, a referral to our network does count as an effective referral.
Thank you, Laura. Hi, so my name's Dr. Casey, and I'm just going to talk about a case that I was an assessor for. And I think why, Laura, I picked this case is it brings up a lot of the geriatric issues that can make MAID a bit challenging for some of our patient population. So this is a lady I saw about, it was last year. So she's 96. She lives in a retirement home. She's been a widower for many, many years. She does have one family member nearby, but this person, he travels quite a lot for work. He does hold both the POAs for her care, but she's really quite isolated. She has 3 sons who they all live abroad. And they find it challenging to come back home and visit her. And unfortunately, she has very significant visual and hearing loss. So they used to kind of communicate by FaceTime and Skype, and that's actually just become more and more challenging as time's gone on. She does have she is quite a religious person. She used to go to church quite frequently, but given her illness, has had to slow down doing that. But she's still getting the occasional visitor from the church. She's a retired legal secretary. There's no financial concerns. And so this is kind of her social history. Oh, sorry. So her past medical history, if you've made it to 96, you don't have very many things that are that overwhelming. This query mild COPD that came from no one was really convinced about that. She was on oxygen, no one really knew why, and so they're calling it COPD, but really she, no risk factors and had never had any major exacerbations. Maybe a mild CHF. Again, if you make it to 96, you'll probably have a small degree of CHF anyways. From a hospitalization, she had a lot of imaging, and so that she did have peripheral vascular disease, but she never had any symptoms, and this certainly wasn't the cause of why she was feeling unwell at present. Hypothyroid, but her TSH was fine, osteoporosis, and she is legally blind, secondary to macular degeneration, and she does have bilateral hearing loss. She was wearing hearing aids, but she's not very helpful. So her medications, as you can see, are very, very clean. There's nothing really on there that could be worsening anything or making anything kind of confounding the picture. She does have a glass of sherry on special occasions, and when I asked her how many special occasions are there in a week for you, she just laughed, so who knows. And no smoking. So from a functional standpoint, we're in geriatrics, this is what we're always very interested in. She was assistance now for all of her ADLs for the past 4 weeks. So she'd been feeling more and more weak, and so she did need assist for bathing, toileting, and dressing. She could eat on her own, but her meals were not coming to her room. And her IADLs, she had been dependent for quite a while. And up until recently, she could walk with a 4-wheel walker. Now she was a 1-person assist with a 4-wheel walker. Cognitively, when we do these assessments, usually meet the person. I definitely had concerns in the assessment with her. Even though it's one of those assessments, as I'm sure you know, when someone is profoundly hearing impaired, you're never really sure, are they not hearing the question? What are they answering? But I did have concerns. And when I was able to talk to different family members, it was kind of like, oh, she is good for 96. And you think, well, that's not really, so I do think there were cognitive concerns in this woman. On a physical exam, she appeared, she was very, very frail and cachectic. She was quite somnolent, but she was engaged. But I have to say the most overwhelming aspect of this whole assessment was that communication was challenging. I had a pocket talker with me. I had a big whiteboard. But because of, again, the hearing and the sight, it was really hard to communicate. So why did this woman request MAID at this time? So actually she had this, she'd been, again, she'd made it to 95 without much wrong with her. And then she was hospitalized 9 months prior with a pneumonia, and she unfortunately got a lot of complications from being in hospital. So she got C. difficile, and then her electrolytes went out of whack, and they actually decided to transition her to palliative care at that time. From all accounts, when she got to Briere, she actually asked, like, well, where's my physiotherapy? I'm ready to get better. And her family all came because they thought that she was dying, and she made a huge recovery and went back to the retirement home almost better than when she came into hospital. And so she'd had this kind of good 8-month stretch, and then about 4 weeks ago, she just became more and more fatigued, leaving her room less, requiring more oxygen. The family doctor who was involved had done some preliminary investigations and couldn't find anything overwhelmingly wrong with her. So when I asked her, I said, well, why do you, what are your reasons for asking MAID? I think she kind of said she's tired of this. When she said, I can't enjoy music and there's no choice in the dining room, her life had become quite limited from her sensory impairments and being in the retirement home. So, if the food was no longer enjoyable to her, she couldn't listen to music, her life had just become more and more sad to her. She was very distressed by her loss of function. She felt useless, and she did say more than once, why spend money on me? Other people need it more. I can't do anything. So this case was, I think as some of you can recognize, so if we're going to go back to the legislation or what is a grievous and irremediable medical condition, it would really just be frailty, right? There's nothing wrong. She doesn't have cancer. She doesn't have ALS. She doesn't, she's just, she meets the definition of someone who's actually very extremely frail. And I guess what I want you guys all to reflect upon is, how do you feel as a profession knowing that frailty is a reason to request MAID, and it's a reason that people do receive MAID? We're very comfortable using frailty in our pre-op decisions or counseling patients on, how they should be making future medical decisions. But I just want to flag it to all of you that it is a reason that people request MAID, and it is a reason that people receive MAID. So I'm a part of the Canadian Association of Medical Assistants in Dying Assessors and Providers, and I actually asked them, I fielded the question to them, how often do you guys provide MAID for frailty, and what kind of assessments do you use? And so frailty is used both for the reason for natural death, foreseeable natural death, and the grievous and irremediable condition. People are very comfortable using the clinical frailty scale in their assessment for this. They put it on the death certificate. And I guess I want to flag to you as geriatricians or people in the field that the MAID assessors and providers do feel a certain level of unease, because this is a complex, frailty is complex. It's very hard, to even label it in a way. Oops, sorry. And what the other thing that these providers came back to me and said is that actually what they see kind of concomitantly when they're in these frailty assessments is these people requesting MAID have a lot of psychological suffering, of fear of going to long-term care. And kind of saying these things, I can't go to long-term care, I'd rather die than go to long-term care. My life would be, so much worse if I had to go to long-term care. And they also said they don't really actually involve geriatricians for these discussions as of yet, which I think is something as a profession we need to think about. And if our colleagues are asking for help, we should probably provide that for these types of cases. Then this woman as well, I did have cognitive concerns for her. I mean, I wasn't there to do a full dementia assessment, but I'm sure you guys all saw this in the news recently, that some people, a handful of people, and Laura knows a bit more about the details ins and outs of these cases, but people with dementia have been successful in getting, in receiving medical assistance in dying, which I think for us is kind of a bit of a, I think when I heard of that, I said, oh, wow, but as we do know, people with dementia can make decisions and do make decisions about their care that is appropriate. And so this person would have received, they would have provided appropriate consent and to be found to be capable for this decision. And I guess, again, another thing we should all reflect upon is that actually the decision of dying or living is actually very simple. It's way more simple than do you consent to us putting a catheter in your femoral artery to go up to your heart to put in a valve that may or may not make you feel better? That's actually, so dying and living is actually a very kind of much easier decision to grasp, yet dying is also something that we use in our common language. As Laura mentioned, people just say, oh, I want to die. And so again, if you have someone who's cognitively impaired, it's very hard. And this woman as well, actually, she kept just saying, I want to die. But do you actually want to die now? Or why do you want to die? And so the language is difficult to tease out, but it is an easier decision potentially. So just something to keep in mind. Dementia is the reason you can receive euthanasia in Holland. And so I'm just bringing this up kind of as maybe potentially what how things could look for us in the future. Just a caveat, but so they think that this isn't the latest stuff. It's a bit hard to tease out because they have how they report things, but really they think it looks like maybe 140 cases since the legislation has been legal, that that's how many cases there have been for dementia in the Netherlands. So as a reason to end your life, to request MAID. So Laura mentioned that a big part issue here is advance directives. And actually, when the legislation was being drafted in Canada, there was a sense people really did think that advance directives were going to be allowed. And it was kind of surprising to, I guess, people in the know that it wasn't allowed. And so this is still an area that could become legal. And I guess for us, I think that would be a huge change in our job if advance directives were allowed for MAID. I think when we'd start to give the diagnosis of dementia, I imagine that a lot of people would then want to start talking about advance directives because that's just how people are. So I'm going to just talk very briefly about this. So they are legal, so people can in Holland, they can write out criteria for when they would like to receive medical assistance in dying. In Holland, really, they have more or less the same criteria as we do. You have to have a medical condition and suffering, et cetera, et cetera. But they do need to meet up with their physician regularly to discuss it if they have this advance directive. And the physician's under no obligation to really follow through with the directive if they're uncomfortable. And from case law, they have some things that say, like, if the person, so say someone said, in my dementia course, as soon as I move into long-term care, please provide me with euthanasia. If the physician then goes to that long-term care facility and they see that the person is refusing their medications, refusing to eat or drink, then that's indication to the physician, this is from case law, that you can proceed with the procedure because clearly this person is still indicating in their deteriorated state that they do not want to live. However, if the person, his behavior is very engaged and they're smiling and laughing and engaged in the programs and taking their medications, even though they're now in a long-term care facility, this could be behavior to say that, the physician shouldn't really proceed with that, even though it was written in advance directive. Does that make sense to everyone? Yeah. It's a very complicated area. And just something to keep in mind that even though a lot of people have put in advance directives in case they get dementia, so this is again in Holland specifically, that not many people end up really enacting it. So it's kind of like what Laura was talking about, that there's a lot of people who just like to have the option of medical assistance dying in their back pocket. It gives them an amount of ease. Same thing with advance directives. They like to know they have it, but really it doesn't really get acted on that often. And I just put this one up. You may have seen this one in the news, but this was was actually a very unfortunate, horrible case, really, of the first time in all of Holland's history of having euthanasia. They did open a criminal case against a physician who was actually a geriatrician, who did provide for a woman who had advanced dementia with an advance directive, and it just didn't go very well. So I think the advanced directives in dementia is going to be a very complex area. It is a complex area in another country, and I imagine that in years to come in Canada, it'll become kind of complex for us as well, and we're already starting to see some of that here. So the kind of issues that, I guess before we talk about this, I'll just kind of give us the end of the case for that lady. I didn't find her capable to make decisions at that time. I actually think she was delirious on the background of having a dementia. And so I turned down her request, and she seemed fine with me, but apparently she told her family doctor later that she was quite upset about that. But she did end up passing away 3 weeks later, comfortably, from what I understand. And that case, I did think about it for a long time because it did, again, kind of have those, like, the frailty, dementia, and I didn't really get a chance to talk about it here, but something I've talked about before is when she's saying she's tired of this, tired of life, is like when we have these people getting into their late 90s, often a lot of their friends have died, a lot of their family have died. They are very isolated. And if you can just imagine kind of the state they're in where they're no longer able to read or listen to music or kind of have conversations with people, that is a lot of psychological suffering as well. And that touches again on that piece that Laura was talking about. That's what really patients come to. It's not so much the physical suffering, but the psychological suffering of the current state of life that they're in at that time. So the other issues that, again, I think Laura and I are trying to convey any message today that things are getting a bit more complex as we're getting more used to the legislation. And the so challenges to access, that I think if you wanted to talk about it, it's very much more a geographical.
Yeah, I think what we, the complexity of the cases we're seeing forward again is in those patients with other chronic health conditions, so less clear that they meet the legal criteria. And when you're seeing MAID in the news, and these are some of the big cases really from the last few months that have gone through, it's in those 3 exclusions to the legislation and patients challenging for increased access. So the Truchon-Gladue finding or ruling in Quebec that was in October, where Quebec has actually overturned the criteria of patients needing to have a reasonably foreseeable death. The challenge that we're seeing of mature minors who want access to this service, and again, as Jen said, through advanced directives. We are having people challenging capacity. Again, that's the advanced directive piece, and that does impact us in terms of looking at patients with a diagnosis of dementia or other neurocognitive disorders. Frailty and VSAT as a criteria for MAID, so voluntary stopping of eating and drinking. So if a patient is found ineligible and then they voluntary stop eating and drinking, go into end organ failure, would they then become eligible? So we're getting into some very complex decision making. It does change the landscape a bit for those of us who are involved, and it certainly speaks to the reason why MAID is embedded in our ethics program in a majority of hospitals across the country. MAID does sit with medical ethics so that we can have that kind of support for decision making. So in terms of what do, we talked about looking at what your college tells you to do. At the Ottawa Hospital, you can make referrals to our program through EPIC, and you can email us, maid@toh.ca, for any inquiries. You can patients can self-refer to us, family members can refer to us, or any member of the healthcare team, and that's our one number to call. We also have a regional website that we're it's just up and launched, but a couple of tweaks that need to be made. So certainly you can direct patients to that for resources as well. We've added this and the slides will be available after today. I think we'll leave it there and open it up to any questions.